Today my topic is epilepsy surgery in Southeast Asia. Efficacy versus challenges. However, I would like to request to change my topics to from challenges to collaborative strategies. This is to match the theme of ASNA this year, fostering ASEAN collaborations. As we know, for those with focal refractory epilepsy, the seizure outcome is better in those who have epilepsy surgery. This is a randomized controlled trial of surgery for temporal lobe epilepsy. And you can see that for those who had epilepsy, the seizure freedom rate is much higher than those in the medical group. However, there are many challenges of epilepsy surgery in Southeast Asia. Surgery gap is a universal problem. It is not only in Asian countries, but also in US, Canada, and Germany. In India, there are 734 epilepsy surgeries per year in year 2016, with over 500,000 potential candidates. This is only constitute to about 0.15% of total candidates. In fact, in Asian countries, epilepsy surgery is also underutilized. This is a survey we performed in our own regions, which has 640 million populations, equals to 8.3% of world populations from 11 countries. There are barriers in facilities, clinicians, expertise, funding, and patients. But as compared to a report in 1999 by Wiesel, he said that there are only 18.3% of economical disadvantaged countries at epilepsy centers. But today, in our regions, 72.7% had at least one epilepsy surgery center. But we know that this is not enough. We would like to have a center at least in every country in our regions. And this is limited by lack of clinicians, especially neurologists, neurosurgeons, and pediatric neurologists. There are lack of subspecialized training. Many of them doesn't have epilepsy or EEG fellowships. There are lack of specialized centers, especially level 3 and 4 epilepsy care centers, and lack of facilities, including video EEG, icterspec and PET, and invasive EEG monitoring. Funding is the main factor, and funding is not only limited to hospital funding, but also patients' ability to pay for their investigations and surgery. In fact, in our regions, each brain surgery is equal to the GDP per capita in most of the countries, and especially in Indonesia, which is highlighted by red line. The brain surgical cost is double the GDP per capita in Indonesia. So which is the biggest challenge? Is it the funding or the expertise? Epilepsy care can be divided into 4 levels. Level 1 will be care at emergency room or primary care facilities. Level 2 is consultation with a general neurologist as in Brunei. Level 3 is non-invasive evaluations like in Vietnam, and level 4 is complete evaluations like in Thailand. Lack of expertise will limit our abilities to proceed further. So in level 1 and 2 facilities, we need at least the routine EEG and MRI. Level 3, we will need a long-term EEG monitoring. Level 3 advanced service include PET, SPEC, or neuropsychological assessment and functional MRI. And in level 4, we will need invasive EEG monitoring services. Some may even have WADA, MEG, EEG, have MRI, or CCP, or connectivity analysis. However, the challenges in expertise development in Southeast Asia can be pre-fellowship or post-fellowship as divided by the red line here. In fact, most neurologists in Southeast Asia are general neurologists. There are lack of exposure to epilepsy surgery. So they may not be familiar with epilepsy, the surgery, the indications and the contraindications, and they may be lack of referrals. In some countries, there may be lack of support and facilities to develop video EEG monitoring, and certain countries, the neurosurgeon may not be interested to work together with the neurologist. There may also be lack of expertise and skills in interpreting PET scan or SPECT, and there may be lack of funding or exposure to perform invasive EEG monitoring in level 4 epilepsy care. So we will need a collaborative strategies for epilepsy surgery in Southeast Asia. In this recent paper published by China, they have about 358 epilepsy centers for 1.38 billion population in China. However, for our region, we have only 41 centers serving 640 million populations, which is almost half of those in China. They have 9,688 doctors in China engaged in epilepsy care, whereas we only have 263 doctors in our regions. So their success is mainly because they have commissions developed by China Associations Against Epilepsy. They have accredited EEG exam, adopted the ASEAN EEG exam format. They are looking forward to develop a database and policies in epilepsy surgery. Adopting this model, these are the strategies that we may consider in our own regions, especially to develop the expertise related to epilepsy surgery. So for our trainees and general neurologists, there is a need to have more educations. We need to have awareness and case discussion platform. We also need to work more closely with our neurosurgeons, have advanced case discussions, especially related to PET and SPECT or other assessments in level 3 epilepsy care. We might need study and database to improve the quality and reduce the gap and accreditations, especially, for example, EEG exam. So the first strategy on educations. As we know now that there are various courses in epilepsy congresses, including International Epilepsy Congress, IEC or AOEC, on semiology, on MRI and neuroimaging, on EEG, and as well as on stereo EEG. However, we know that most of these training, they are either for those who are subspecialized in epilepsy, but not for trainees or for general neurologists. These courses can be complex and not applicable locally, especially in limited resources setting. And some of these courses can be expensive. For example, this one in Singapore. In our region, in fact, we need more basic courses for trainees and general neurologists. In order to have accurate localizations and lateralizations, we will need to depend on semiology, EEG, and MRI. But we know that these are not easy for general neurologists who are not familiar with epilepsy pre-surgical evaluations. Interpretation of semiology, EEG, and MRI require guidance and practice. The classifications of seizure types by ILA in 2017 is also inadequate for seizure localization and lateralizations in pre-surgical evaluations. Therefore, we have organized multiple EEG courses in our regions via ASEAN Epilepsy Academy. This is one of the EEG courses in Malaysia. And last year, we have organized the first video EEG course for beginners, focusing on the needs to have video EEG and how we interpret MRI and video EEG in related to focal epilepsy and refractory epilepsies. In fact, we need more basic epilepsy causes in our regions. As we know, in China, every year there are multiple causes for trainees and general neurologists and those who are interested in epilepsy, including basic courses in semiology and EEG and MRI, and advanced courses on stereo EEG or invasive EEG monitoring. Second strategy will be to improve awareness and discussions platform. There are many large-scale case discussions. For example, this one organized by Indian Epilepsy Surgery Society, and this one by the ILAE Asian Oceanian Commission's Epilepsy Surgery Task Force on cases with step-by-step guidance. However, these case discussion sessions are infrequent with limited discussions, and the time for Q&A are relatively short. In fact, we need a platform for these discussions in our regions on a daily basis. For example, in MRI interpretations, we know that surgical outcome is better in those with abnormal MRI, as we can see in these plots on the left showing that those with abnormal MRI has better surgical outcome. However, we know that about 20 to 40% of our epilepsy surgical cases are MRI negative. In fact, most of the times these lesions are subtle and they was reported normal by the radiologist. It is missed because the epilepsy MRI protocol was not performed, or the MRI was not reviewed by a neuroradiologist with interest in epilepsy. And some of these MRI require additional MRI post-processing. And because of this, there are only 5 countries in our regions that can perform pre-surgical evaluations for MRI negative cases, and most of these require invasive EEG monitoring. However, if we have a platform for discussions, for example, using Telegram signals, WhatsApp or WeChat online, and we can maintain private within a center, a country or regions by anonymize the patient's information, the general neurologist or the trainees can share the videos of the patient's MRI or EEG, or sometimes even discuss on treatment plan. And this can be performed on a day-by-day basis. For example, the picture on the right is a group in Malaysia where we share EEG, MRI, or short cases, sometimes related to epilepsy and epilepsy surgery. So the third strategy I propose will be a partnership with neurosurgeons. Most neurosurgeons in our regions are not interested in epilepsy surgery, or they are unable to specialize because there are only a few epilepsy surgical cases a year. So most of them will still continue their work in tumor, in spine, or in other fields of neurosurgery. To increase their interest of neurosurgeon, we may need to consider to have more multidisciplinary case conference, either within the hospital or inter-hospital. We can have a conjoint conference, for example, this one, Asian Epilepsy Surgery Congress in 2021 in Korea, which is suitable for both neurologists and neurosurgeons interested in epilepsy. We may also need to consider organizing courses that include both neurology and neurosurgery aspects to be attended by both parties, including neurosurgeons, as well as having interactive sessions, as I showed you just now, by ILAE Asian Oceanian Commissions. Strategy 4 will be having advanced case discussions, especially on those with complex epilepsy syndrome or difficulty in determining the localization of epilepsy surgery. There are multiple inter-hospital case conferences, for example, one in between Thailand and Malaysia. But in fact, we need more regional support and collaborations. For example, in sharing of protocol, either in video EEG monitoring, MRI, or PET scan, or collaborations or technical collaborations in syscom processing, or PET MRI call registrations, or MRI post-processing, like in this voxel-based morphometric analysis. Sometimes we may need even EEG source imaging processing for certain EEGs. This is one of the examples of sharing of protocol where we share our epilepsy MRI protocol using various modalities and sequences. We also share our video EEG monitoring, which is suitable for resource-limited setting, whereby we only perform 48 hours monitoring for patients with focal refractory epilepsy. Sometimes we may face challenges, and we can share our experience on how we overcome the challenges in epilepsy surgery, especially in setting up video EEG monitoring and performing invasive EEG monitoring, like in this paper. Strategy 5 is to develop a multinational regional combined studies or database. So some of the study that we can consider will be regional survey, audit of epilepsy surgical care standards. One of the review we perform in our regions show that there are a great management gap, especially in epilepsy surgery in our regions. There is a need to study this gap and improve the gap. Otherwise, our epilepsy care standard may not improve even in the next 5 to 10 years. A database was proposed by the ILAE Asian Oceanian Commissions under Epilepsy Surgery Task Force, and we should consider that as well, either to join the task force or to have a separate database in our regions. Database is needed for multi-centered studies and also needed to audit our quality of care and to determine how we can improve our care further. This is specifically important and different from the developed countries because most countries in our regions are working within a resource-limited setting. So this is one of the examples of regional collaborative survey in which the results were presented in the early part of these talks. Last strategies will be on accreditations, and one of the accreditations we can consider will be ASAPA EEG certifications examinations. This is to ensure the EEG reporting accuracy and quality in our regions. So the 6 strategies that I have proposed will need a strong collaborations within our regions, and we might consider the need to develop an ASNA Epilepsy Surgery Commissions, matching our theme this year, which is fostering ASEAN collaborations during COVID-19 pandemics or even after the pandemics. So if you have interest or if you have any ideas, please contact me using the email stated below, and I would like to acknowledge our UMMC comprehensive epilepsy units, which include our neurologists, neurosurgeons, pediatric neurologists, our neuroradiologists and neuropathologists, together with all our neurotechnologists. Thank you very much.